Kia ora, Stephen. Tēnā koutou, ngā hui mai nei o te motu. Nau mai ki tēnei hui mo te kaupapa i tēnei rā. Ngā mihi o te tauhou Māori kia koutou. He karakia tīmatanga kia noi tātou. Mana mai te pūtanga o Maturiki. Mana mai te ariki o te rangi. Mana mai te mātahi o te tau. Whanno, whanno, hara mai te toki huaki rangi. Haumi e, hui e, tāiki e. Kia ora tātou. He rākau, Katie.
Well, tēnā koe mātua Guy. Kia ora koutou, no mai haere mai. Welcome to our webinar today. Huge privilege to have you all here. Just I'm going to do a little bit of housekeeping, but kia ora. Ko Katie Sheriff toko ingoa. So just a little bit of housekeeping about our webinar today. If you have a patai, a question throughout, please use the Q&A function. So it's a little box on the bottom of your screen with a question mark in the middle. You are welcome to use the chat if you want to introduce yourself, say kia ora to anybody, that's absolutely fine. If you want to ask a question in Q&A, it will be anonymous, whereas in the chat, we can all see who you are, which is fine. You can also message each other privately, which is kind of fun. This webinar will be recorded. You will not be shown on this. Your cameras are turned off and you are all put on mute. So there's nothing wrong with your Zooms. That's just how this webinar will work today. We will send out a recording that will be available on our website and on YouTube. And after the webinar, there will be a feedback form. So please tell us what you think, what we did well, what we can improve on. That just helps us get better every time. So I am going to now hand over to our speakers and our panelists today for the introductions. Matua Guy, I'm going to hand back to you.
Kia ora, Katie. Tēnā koutou anō. Ko Guy Baker toko ingoa. He uri au o te iwi o Ngāti Parau. He mahi au he kai tohu whiako Māori mō te Haerenga Mahara. My name is Guy Baker. I'm an East Coast boy working for the Mental Health and Wellbeing Commission as a principal advisor for Māori whānau lived experience. Kia ora no tātou. And we're handing over to Natalie, are we?
Tēnā koutou, ko ingarangi te whakapaparanga mai, ko te awa kairangi te kāinga, ko Natalie Horsbull toko ingoa. I'm a principal advisor here in the Mental Health and Addiction team. I know as one of the authors of this report alongside colleagues who are working behind the scenes today. So handing over to you, Ainsley.
Tēnā koutou katoa. He uri hau o te waka o Tainui, ko Ngāti Maniapoto, Ngāti Tamatera, Ngāti Kauwhatinga iwi. Engari e noho anō ki te tongo Tamaki Makaurau, i tipu ake au ki reira. E mahi ana hau mō te National Hauora Coalition, kua hau he kai mātai hinengaro. I taku mahi mō te National Hauora Coalition, kua hau te kai hautu o ngā kaupapa rangahau. I'm Ainsley from South Auckland, Waikato girl, and my mahi with the National Hauora Coalition is the Director of Research and Evaluation, and I'm a clinical psychologist by practice and training. Kia ora koutou. Watu te rākau ki a koe, Sonia.
Kia ora koutou. No Croatia me Ngāpui o ko tupuna, ko Ngāti Pākau toko hapu, ko Tāhiki toko marae. Ki Tamaki Makaurau ahau I noho ana. Ko Sonia Russell toko ingoa. Ngā mihi noi kia koutou katoa. Kia ora, I'm Sonia Russell, the Director of Mental Health and Addiction Sector Leadership here at Te Haerenga Mahara. Thanks very much for joining today, and I'm going to kick us off and provide a bit of an overview to our monitoring reports, and then Natalie is going to follow and provide a bit more detail. So kia ora. Kia ora. So look, I think while we're getting our slides up, I'll just kick us off. So Te Haerenga Mahara, the Mental Health and Wellbeing Commission, was set up in response to Hiara Oranga, which was the report of the government inquiry into mental health and addiction in 2018. And this inquiry captured the voices of people right across Aotearoa, New Zealand, about their dreams and aspirations for improving mental health and addiction services. Te Haerenga Mahara's overall objective is to contribute to better and more equitable mental health and wellbeing outcomes for the people of Aotearoa. We're an independent Crown entity, and we are kaupapa driven and committed to being grounded in Te Tiriti o Waitangi. Our key functions are around system level leadership, systems level oversight, leadership, monitoring, reporting and advocacy. Through our monitoring work, we highlight the things that are working well as the things that are not going so well. We advocate for change and we aim to add value by using the levers we have to smooth pathways and enable the changes needed to make a real difference for people and their whānau. Also, now you get to see our beautiful graphics of Te Haerenga Mahara. So we'll just keep moving. So I've just talked to that, so we can move on to the next slide. Kia ora. So this is Hiara Āwhina, which is our Pathways to Support framework. In June 2022, we published this framework, and this was co-developed with lived experience communities and many people right across the sector. It describes 12 domains that together express what an ideal mental health and addiction system looks like. In our 2023 report, we identified a decrease in access to mental health and addiction services, which is why we wanted to focus on the access and options domain for this year's report. So our monitoring this year has 4 components. And so the 4 components are our main monitoring report, which is what this webinar is focused on, Kua Tīmata Te Haerenga. We also published the Voices report, which brings together the main report, but has quantitative and qualitative data and that has informed that report. The accompanying Voices report focuses on the qualitative data, and we wanted to produce that report because it provides a richness and depth to the narrative and the stories that we heard. We're also in the process of publishing 3 infographics, which will be released over the next couple of months, and those are focused on our particular areas that for our advocacy work, rangatahi and youth, kaupapa Māori services, and reducing coercive practices. And we've also released an updated dashboard. Our online dashboard, which you can see here, provides updates to the 68 measures that we use to monitor all 12 domains of Hiara Āwhina in an interactive format that allows data to be shown over time by ethnicity and age group. And that's available on our website. So for this year's report, we set out to gain a much deeper understanding of the changing patterns in access to mental health and addiction services over the last 5 years. The access and options domain is about the right to choose supports and services when and where they're needed in response to experiences, needs, and aspirations to enable us to thrive. It includes understanding inequities in access for Māori, rangatahi and youth, and for different population groups. We also wanted to dig deeper to understand the factors contributing to these changes and understand the range of service options available. Kua Tīmata Te Haerenga, the journey has begun. The title of this report has been provided by Ngā Ringaropa, which is the collective of Māori kaimahi within Te Haerenga Mahara. It reflects how the journey to apply Hiara Āwhina as our monitoring framework has begun, which this year led us to monitor the access and options domain in much greater depth to understand how and why access and options have changed over time. It's accompanied by the Voices report, which provides the richness and depth to honour what we heard from tangata whaiora, communities and the mental health and addiction workforce across Aotearoa, New Zealand. Both of these reports were published on the 5th of June. Our monitoring report covers the 5-year period from the 1st of July 2018 to the 30th of June 2023. And it covers services funded through Vote Health and emergency responses. We use both quantitative, so numbers and measures, and qualitative narratives and stories to help us understand why service use has changed and the options now available to people. Our approach was designed to ensure diversity in perspectives and experiences from people with lived experience, whānau, priority population groups, and the workforce. Many people contributed their wisdom, experience, and expertise to our reports. We thank the agencies who supplied the data, those who guided us as members of the reference groups, and the hundreds of people who shared their experiences of accessing or trying to access services. There was quite a lot going on in the 5-year period of our monitoring, with three quite major shifts. So there was the Hiara Orangata report and the response to that in the 2019 wellbeing budget. We could never forget the COVID-19 global pandemic, which caused huge disruptions across New Zealand and worldwide. And the restructure of the health system, in which 20 district health boards were replaced with Te Whatu Ora Health New Zealand and Te Aka Whai Ora. In our report, we've included calls to action, which are the changes that we consider to be critical to improving the mental health and addiction system for tangata whai ora and their whānau, and 5 recommendations, which are more specific about who needs to do what to achieve that system level change. I'll hand over to Natalie now, who will go into these in a bit more detail in the next section. Kia ora, Natalie.
Kia ora koutou. As Sonia has mentioned, the monitoring report has drawn on a wealth of data. This includes over 40 quantitative service performance measures and hundreds of voices shared with us from the community and people working in services. This 2024 report is our 3rd mental health and addiction service monitoring report. Our earlier 2 reports drew largely on quantitative data. This year, we have strengthened our approach, and it's the first time we've collected qualitative data for our main service monitoring work. Having a mixed methods approach enabled us to monitor service access and options in more depth. It also ensures the experiences and voices of people with lived experience are at the centre of our work. You may be interested to hear that in most cases, the quantitative data lined up with what we heard from people in the community and people working in services. This triangulation supported the strength of evidence in the monitoring story. In presenting these slides, I will share selected findings from our reports. I won't go through all the findings. More detail is available in our reports on the website. Here are the headline findings from the monitoring report. There is much more nuance that I'll step through in the next slides, but if you're after the main takeaways, this is it. In summary, the monitoring report found a mixed picture. It is promising that the new Access and Choice program has significantly increased access and expanded options for people with mild to moderate mental health and addiction needs. However, alongside this, we heard that people are having difficulty accessing specialist services. Fewer people are accessing specialist services compared to 5 years ago. We found this decrease in specialist service use is largely due to changing needs and chronic workforce shortages. The quantitative data and qualitative voices come together to tell an overall story about access to mental health and addiction services and options available. This visual here illustrates this story. As we know, with complex systems like the health system, changes to one part of the system impacts another part. There's a lot of detail here in this slide, but we'll step through this more in the next few slides. To monitor access to mental health and addiction services, we firstly need to know what is the level of need. This is so we can monitor whether access is aligned to need. The best source of evidence on the level of need and subsequent demand for mental health and addiction services is a population prevalence study. However, the last prevalence study was conducted in 2003 and 4, Te Reo Hinenaro. Given this data is now 20 years old, it does not reflect current need. It is urgent and essential to have prevalence data to align service capacity to need and future investment in mental health and addiction services. Despite not having prevalence data, we conclude that the level of need for services is not decreasing. The New Zealand Health Survey shows that levels of psychological distress continues to increase. While this data is somewhat limited to show service need, it does give an indication of trends. Alongside this, we continue to hear about increasing demand for services. People within the sector tell us that people are presenting with more acute distress and more complex social needs. In recent years, the impact of the pandemic and cost of living has created additional stress. This visual illustrates the changing needs and service responses. A triangle is often used to depict the level of need in the total population and services designed to respond to that need. Mild to moderate needs are at the bottom of the triangle, moving up to severe and complex needs at the top of the triangle. As mentioned in the last slide, we heard how the level of need in the population is changing, illustrated in that top triangle. Alongside this, there's been increased investment into primary care services through the Access and Choice program. This has helped improve access for people with mild to moderate needs. This second triangle shows how the use of services for these people has increased. However, there is decreasing use of specialist services. This is largely due to increased pressure on the workforce by high vacancies. Some people working in primary care perceive that the threshold for acceptance into specialist services has become higher. Some referrers are reducing the number of referrals they make and are supporting people for longer in the community while waiting for access to specialist services. There also might be some success in early intervention with the Access and Choice program. Some people with moderate needs who would have previously been referred to specialist services are now receiving the support without the need for specialist care. This all comes together in the third triangle to show how specialist services are targeting limited resource to people with the highest needs. It is the people in the middle that is concerning. People with needs above what can be supported in primary and community care, but who cannot get timely access to specialist services. Now to give you a bit more detail on these summary findings. The rollout of the Access and Choice program started in 2020. This was in response to one of the recommendations in the 2018 government inquiry, He Ara Oranga. It is intended to increase access to publicly funded mental health and addiction services for people with mild to moderate needs. There are 4 service types in this program: integrated primary mental health and addiction, kaupapa Māori, Pacific, and youth. In the 2022-23 financial year, 3.6% of the population used Access and Choice program services. This is nearly 186,000 people accessing these new services. We heard from many people that access to primary care is easier due to this program. We also heard from staff working in services of the benefits of the program in being able to offer people support, what GPs can provide in a scheduled appointment. We heard this provides people timely access without additional barriers. While this is positive, the rollout of these services is still continuing. As of June 2023, 64% of the population enrolled with a GP had the integrated primary mental health and addiction services available to them. While access to primary and community services has increased, access to specialist services has decreased over the 5 years of our monitoring. The proportion of the population accessing specialist services has decreased from 3.8% in 2018-19 to 3.4% in 22-23. This equates to around 9,300 fewer people using specialist services over the 5 years of monitoring. People told us how access to specialist services is difficult. We heard this from both people in whānau trying to access services and people working in primary care. The decrease in access is larger in addiction services than in mental health services. Addiction service use decreased 15.9% over the 5 years, compared to a 3.1% decrease in mental health services. The scope of the monitoring report also includes a range of other mental health and addiction service types. We included data on the use of national telehealth services provided by Whakarongoto. These include, for example, the well-known 1737 service. Over the 5 years, the use of these telehealth services peaked around the time of the first COVID-19 lockdown, but decreased by 11% in the last year of monitoring. However, the number of contacts over these 2 years is similar. This suggests that while less people are using telehealth services, those who do are calling or texting more frequently. We also heard that telehealth services are dealing with more complex calls and more calls about risk of harming themselves or others. Wait times for national telehealth services have also increased significantly over the 5 years. We also looked at online platforms. The number of online platforms and apps available to promote mental health and wellbeing is growing. Our monitoring looks at just a few selected online platforms. Use of mental health online platforms, depression.org.nz and The Lowdown, have been decreasing since 2020-21. In contrast, use of the Drug Foundation's The Level has grown significantly as an online harm reduction platform. Use of primary mental health initiatives have decreased over the 5 years. These are services distinct to the Access and Choice program, and they are delivered by primary health organisations since 2003. There are some data comparability issues with observing changes over time, but we do see and hear about how use of these other primary mental health initiatives have decreased, partly due to the Access and Choice program. Medications are another option available to people experiencing mental distress. Our last year's report raised the finding about the increasing use of medications, particularly for young people. However, this trend has now started to turn, as seen in this graph on the right. The monitoring report also covers emergency responses by police, ambulance, and emergency departments. The number of mental health calls to police has increased year on year. Mental health calls, coded 1M, have increased by 64% over the last 5 years, shown in the light blue line in the figure 2. The dark blue line shows that the number of calls police attend is similar over the 5 years, but as a proportion of calls, this has decreased. It is important to note that some of the calls that police code as mental health may be for a range of social issues and may not require a mental health response. Like police events, ambulance events about mental health have increased. While ambulance staff are receiving more mental health related calls, we also heard the needs of people they are responding to are more diverse. Our data includes both Hatohone, St John and Wellington Free Ambulance. In contrast to these trends, the number of presentations to emergency departments related to mental health increased up to 2020-21, but has since decreased. The ED data shows that average wait times to transfer to mental health inpatient services has risen significantly over the last 5 years. Although it involves a long wait to be seen, many people see ED as a short entry point to the hospital specialist service when people are in crisis. Workforce shortages are evident across many parts of the system. Most notably, we heard about workforce issues in specialist services and in GPs. The size of the workforce, both employed and vacant, has grown over the 5 years. But this workforce growth has been largely offset by increasing vacancies. In adult specialist services, vacancy rates doubled between 2018 and 2022, from 5.5% to 11.1%. Vacancy rates have continued to grow in the last year of our monitoring across all selected roles. Data from Health New Zealand shows this is particularly high for some roles. Vacancy rates for psychologists are 22%, drug and alcohol counsellors at 13%, psychiatrists at 19%, and registered nurses at 14%. Staff from across the sector shared that vacancies continue to put pressure on service delivery and reduce access to services. Even though specialist services are seeing less people, this does not mean that people working in these services are doing less work. The persistently high workforce vacancies are putting additional pressure on the remaining staff. We heard from interviews with staff that the capacity constraints are leading to a focus on the people with the most severe and complex needs. The result is that staff already working under pressure are put under further pressure due to more complex caseloads. This is compounded by people presenting with higher needs, such as increase in multiple issues, drug use, housing instability, and neurodiversity. The workforce issues also contribute to a significant loss of experience. As mentioned in the last slide, there are high psychiatrist and psychologist vacancies. Without people in key roles mean many specialist interventions can't take place and less supervision is available to support the new workforce coming through. Staff managing more complex caseloads is more resource intensive. For example, average length of stay in an inpatient unit has increased and measures of intensity of service activity have increased, such as average events per week. But people are moving through services and specialist services are seeing a higher proportion of new people and a reduction in people who use services long term. The number of referrals into specialist services has decreased over the last 5 years. We heard this is due to primary care responding to constraints in specialist services, not due to decreasing demand. While the number of referrals has reduced, the acceptance rate for referrals has increased. Wait times are one of the few areas where the quantitative data does not align to the qualitative. The quantitative data shown here shows slightly longer wait times over 5 years, but leveled off over the last year. However, people have told us that wait times have become considerably longer. Part of the difference between the quantitative and qualitative is likely to be due to what the wait time measures. The quant measure is the first contact, which is only one part of the wait that people experience. Our report contains key findings for Māori and for rangatahi and youth. This slide presents some of the quotes of what we heard from Māori, either trying to access or working in services. While some Māori and whānau found it easy to navigate and access services, many reported experiencing a wide range of barriers. Māori and whānau reported disengaging from the system due to poor previous experiences. Māori explained they've already experienced discrimination and are sensitive to judgment, stigma, or discrimination based on either their ethnicity or their mental health issue. While there's growing recognition of kaupapa Māori services, often they are under-resourced, not widely available, and not regarded as equal to mainstream services. Kai mahi Māori go above and beyond using applied Mataronga Māori practices or models of care that improve outcomes for Māori and their whānau. We also have an upcoming infographic focused on the use and investment in kaupapa Māori services. Rangatahi and young people are navigating unique challenges, such as climate change, a global pandemic, and an increasing online world. The Access and Choice program has improved access for young people in all 4 service types. As mentioned earlier, medication dispensings for young people have decreased for the first time in 5 years across all medication categories. However, concerningly, wait times to access specialist child and adolescent mental health and addiction services for people aged 0 to 18 years remain higher than wait times for adult services. Furthermore, young people aged 19 to 24 years have a higher access rate to specialist services, but as you can see in this graph, this has decreased at a faster rate than other age groups. If you're interested in the money side of things, the total expenditure on mental health and addiction services increased from 1.53 billion in 2018-19 to 2.28 billion in 22-23. This equates to 9.5% of total health appropriation. Increase in expenditure is largely driven by a 240 million annual increase in services delivered through Health New Zealand. The Access and Choice service delivery has also been an additional 164 million spent in services new since 2020. Investment in services for children and young people has not risen at the same level as other parts of the system. Investment in Māori mental health and addiction services or teams continues to increase. Most of this expenditure, 87%, is in NGOs rather than Health New Zealand services. The monitoring report also shines a light on areas that are working well in the system. We want to acknowledge the thousands of hardworking staff working in services who provide care and support to people every day. We heard about examples of what is working well. As mentioned earlier, the Access and Choice program is working well. Health improvement practitioners and health coaches are improving access to people to primary care. Primary care liaison roles are bridging the gap between primary care and specialist services. Multi-agency co-response teams have been established between emergency and health services. In addition, earlier mental health response phone services are able to get faster and more appropriate help to people in psychological distress who call 111 and ask for a police or ambulance service. I've now presented to you a selection of key findings from the monitoring report. Drawing on the evidence from the monitoring, we published recommendations on what we want to see change to accelerate improvement. Sonia earlier mentioned some of the broader areas of system change, and our report includes 5 specific recommendations. These recommendations are the who needs to do what. These recommendations you can see here are in 5 areas. Firstly, about developing a workforce plan. Secondly, about meeting the needs of Māori and whānau. Thirdly, about acute community options for rangatahi and youth. Fourthly, about a data plan to improve quality and timely data. And lastly, about the funding of prevalence data. Our recommendations are directed to relevant entities, the first 4 to Health New Zealand and the prevalence study to government. We have also set deadlines on when these recommendations should be completed by June 2025. We will monitor progress against these 5 recommendations. These recommendations are just about the access and options domain, which was the focus of our monitoring report. We will build on these and make recommendations for other areas of system change in the future. I will now hand over to Katie to facilitate the question and answer portion of this webinar. But before I do, we just want to say to anyone attending this webinar who is currently trying to access services or have whānau members who are, please know that help is available. Our website has a list of services of where to get support. Ngā mihi.
Oh, kia ora, Natalie. Thank you so much. It's so important that we have such a comprehensive overview of what's happening with supports and services at the moment. We do have some questions